speaker. It's Dr. Kyulim Lee. The title is Oral Care Essentials After Transplant. So we know that oral cavity is site of most common complications after transplant. And Dr. Lee is an assistant professor in the Division of Pediatric Dentistry at the Ohio State University College of Dentistry and the pediatric dentist at Nationwide Children's Hospital. She is a board-certified pediatric dentist and an NIH-funded clinical researcher. She earned her Doctor of Dental Medicine degree and a PhD in microbiology at the University of Florida. She later completed her Master's of Science and residency in pediatric dentistry at the Ohio State University, Nationwide Children's Hospital, and her current research examines bacterial, genetic, genomics, and microbial ecology as they relate to oral and systemic health, with a particular focus on the oral microbiome in pediatric patients undergoing hematopoietic stem cell transplantation. So we look forward to hearing about your work. Thank you.
Still morning, so good morning, everyone. Thank you for the opportunity to talk to you guys about a very important aspect of post-transplant care, which is the oral care essentials. I'm actually giving this talk on behalf of Dr. Jacqueline Mace from the NIH. She was supposed to be here, but obviously can't be here due to federal travel restrictions. So it's a huge honor, to be here in her place to give this talk. This is sort of the objectives, what I want to cover today in our talk. And again, Dr. Jacqueline Mays shared her slides with me, so I'm very thankful of that as well. We will discuss the general oral care after transplant, what that looks like. We'll discuss some oral complications that you might be experiencing after transplant that is related to graft versus host disease and some that are not. We will discuss the symptoms that you could experience when you're experiencing oral chronic graft versus host disease, as well as discuss different types of it and discuss different treatment modalities that's available at this time. A quick roadmap of our talk today. The very first key message is take care of your mouth. This sounds very simple, but it is foundational, and we'll go over sort of what aspects that could entail, including one, how to find a dentist, who to look for, what to ask, importance of oral cancer screenings. And we will discuss about some of the complications that you might experience, again, as non-GVHD symptoms, and specifically that you will experience as you have GVHD symptoms. Sometimes they present differently in the mouth. We'll go over that in detail. So before we get started, I kind of wanted to discuss a little about the oral anatomy and dental terminology that I'll be using throughout the presentation today. So the oral cavity of the mouth is really a gateway to the entire body. It's a site in the body that we often see early signs of systemic diseases or systemic conditions, and also the immune function. It's more than just the teeth. We have the gingiva, the gums that cover the teeth. We also have this soft tissue lining, this moist tissue that surrounds all around the mouth, and that is the mucosa. There are tissues that lines inside of the cheeks bilaterally, and those we call buccal mucosa. Now, like I said, the oral cavity is a very unique part of the body. It's the only part of the body that's openly in constant contact with the external environment. So naturally, there's a lot of natural defenses that's available, and there's a lot of immune function already built in. There are certain areas that have active immune system. One, like the tonsillar regions. This has, the tonsils have a lot of immune function, as well as the sublingual aspect. So underneath the tongue is where we also see a lot of the immune responses. Now, we have three major salivary glands in our mouth. We have one parotid gland, we have the submandibular, we have the sublingual glands. These three are the major glands that produces that that watery saliva in your mouth. But beyond that, we have maybe over 2,000 to 3,000 minor salivary glands that are equally important. They also produce some amount of that saliva in your mouth. And they're particularly important because they reflect the state of the function of your major salivary glands, whether that's the immune state or the pathological state. The minor salivary glands are the ones that sort of reflect how your major salivary glands are functioning. Now, how should we take care of your mouth post-transplant? This is really very similar to how you should be taking care of your mouth pre-transplant. But there's going to be different elements because your mouth is going to feel different and it's going to feel a little sensitive, post-transplant. Number one thing I like to emphasize to our patients is to use fluoride toothpaste. Now, your teeth is that the most outer layer of your teeth is composed of the enamel, which is the most hard mineralized tissue. As you're going through transplant and post-transplant, your teeth, that enamel layer might have been exposed to different environments. One, your diet might have changed to a more karyogenic diet, meaning you're eating more of the sugary, high source diets. I'm gonna close my eyes with all these like sugary snacks that we have and the desk on the tables right now. Also, you might have been, with nausea, you might have been vomiting, and these teeth might have been more exposed to acidic environments. And common, symptom we see is dry mouth. So your teeth might be in an environment that there's reduced salivary flow. And all of these really increases the risk of you getting dental decay or dental cavities. And so fluoride is the important molecule that really helps remineralize these softened parts of your teeth and these demineralized aspects of your teeth. So I recommend you guys using the fluoride toothpaste. Now, you might just have a sensitive mouth. You might all of a sudden not be able to tolerate the most common toothpaste that contains mint flavor. In those patients, I like to recommend using fruit flavored ones, or even children's toothpaste. These are a lot gentler to your tissues. You might have sensitive teeth now. Fluoride rinses or gels could be prescribed or provided. Your dentist could provide you a higher fluoride containing toothpaste called Prevident that could also be helpful in this controlling the sensitivity. And also the flavor is a little gentler, so it oftentimes feel better on your mouth. We also have desensitizing toothpastes. There are several ones that are listed here, but Sensodyne is one that I like recommending to my patients because Sensodyne also does not contain SLS, which is sodium lauryl sulfate that causes that foaming agent in the toothpaste. So these foaming agents sometimes exacerbate that dry mouth sensation in your mouth. So this is something that I like to recommend in our patients that have dry mouth and also experience some teeth sensitivity. One important thing to note is that it takes a little bit for these to work. So you use it one day and then it's not like you'll see results immediately. So just give yourself a little bit more patience. If your teeth are extremely sensitive, you can get professional desensitizing treatment with your dentist. And this could be just as simple as getting additional fluoride in office, or this goes all the way up to providing even like laser therapies to help control this sensitivity. If you have limited joint mobility, electric toothbrushes are something that we recommend. The electric toothbrushes have smaller heads of the toothbrush, so it's easier to reach sort of the areas that are far back. One thing I love recommending my patients, and I'm a pediatric dentist, but I did practice as a general dentist before, so I did see a lot of my older patients. So for these patients, I like to recommend even children toothbrushes or even taller toothbrushes. You'll notice that the heads are way much smaller and the bristles are much softer. So these are very, very helpful to reach the far back areas or even areas that are harder to reach with like a big toothbrush. So the key message here is that you want to use what works for you. And these little tweaks will help you better maintain your oral health. Flossing is very important for maintaining your gum health. I think this is, it could be complicated because some transplant centers ask you to refrain from flossing But they don't really tell you when you can resume back, with the normal flossing. And generally speaking, typically, if you have stabilized with your transplant, and unless there's like a specific medical reason, most of the time you are okay to continue flossing. These little strips of flossing are difficult to use, and myself included. So water picks or electric flossers are another tools that you could use. And then I love these little Christmas tree flossers. If you have more space between your teeth, these are great to sort of go and reach those areas to get that debris out for your gum health. Now, finding a dentist or having a dental home is very important. At Nationwide Children's Hospital, I see a lot of patients pre-transplant and post-transplant, but I'm not their routine dentist. And this might have been you. And so it's really important that you have a dentist that's local, that you can go for just preventative work as well as just regular cleanings. Tell them that you're a transplant survivor. This is an important detail that should be shared so they can tailor their care towards you. If they look a little confused and that they don't really seem familiar with the transplant process or how to manage, then that's okay. Like, it's okay to look for another dentist. When you go to a dentist, it does happen. When you go to your dentist, you want to show them, all these lesions, bumps, lumps, color changes, textures in your mouth that you see. The previous speaker had mentioned that, you yourself is the best second eye outside of the physician or the dentist, etc. So if you notice anything, show them to your dentist. And usually these lesions should heal within 3 weeks, but there is an asterisk there because this timeline unfortunately doesn't include patients that have graft versus host disease. Do you ask for an oral cancer screening? This is particularly important for patients that have had oral chronic graft versus host disease, and we will discuss this in a little bit. Now, again, not every dentist might be able to appreciate your medical needs or your medical history. So if you feel like you're going to dentists that really don't have a good understanding of this, then it's totally fine to look for another dentist. You can start that conversation just by asking, do you have experience in treating complex medical patients? Typically, university dental clinics as well as hospital dental clinics have a lot of providers that are more experienced in managing these layered medical histories. And oftentimes, if you do have oral chronic graft versus host disease, you might need some specialty treatment, and oral surgeons, oral pathologists, or even oral medicine specialists are the ones that I would definitely see because they have been seeing this for a longer time. Getting an oral cancer screening yearly is extremely important. Now, this is particularly important in this population, and especially if you have a history of oral chronic graft versus host disease. The period of time where that risk is higher is 5 to 10 years post-transplant. And the site in the mouth that we more commonly see these presentations is around the tongue, on the lateral borders of the tongue, so the sides part of the tongues. This is a photo that was shared by Dr. Mays, and it's a patient that had this lesion, and this is a presentation that they noticed this, 2 to 3 weeks prior to that photo, and this was 5 years post-transplant, and that ended up being oral cancer that needed a lot of treatment. So, one, I don't want you to start worrying about this, and this is something that you worry every night. The risk of getting oral cancer in general is very low, but this yearly screening is therefore important. So, I keep an eye on it, you keep an eye on it. It's something that we just continuously monitor. Oh, one thing I was going to mention is that this oral cancer screenings are very simple, very non-invasive. Your dentist should be looking at your mouth very thoroughly, and it might already be part of their routine exam. They might take a gauze, move your tongue around, try to look in the back of the throat, palpate around your jaws, underneath the chin. That is all part of that routine screening. But if they're not doing it, ask for it. So, were you going to? The matter of them looking at it. Yes, looking at everything. Yes, visually. Right. So the oral post-transplant complications generally follow a trend, and but there is some good overlap. So you might experience mucositis, dry mouth, or thrush the early part of your transplant, and then the overlap period usually results from drug-induced complications from your systemic dose of methotrexate or sirolimus. It could be also secondary to viral infections that have reactivated or flared up, and that's usually from herpes simplex virus and human papillomavirus. And then late transplant period, those oral complications might be due to the chronic GVHD, and then the symptoms will go into a little bit more detail later on. And also, some of the complications could be secondary to the oral cancer that we just talked about. Now, let's discuss some non-GVHD post-transplant complications. First and foremost, the loss or change in taste. So this can be something that could be related to the chemotherapeutic agents you received in the past. It could be something that appears suddenly, and it's like how your mouth perceives taste and texture as well. So things that you used to eat and enjoy, like meat, you no longer want it because it just tastes and then it feels different in your mouth. You can be experiencing radiation-induced dry mouth, and this can also appear very suddenly, which we will discuss in a little bit. You might also have medication-related oral ulcers or lesions that will be needed to be monitored and then discussed with your dentist and your physician. And when you're post-transplant, you go through an immunocompromised state. You're constantly, fighting various infections, and a lot of the infections are caused by normal, like organisms that are normally part of your body, and it wouldn't have caused a problem if you weren't immunocompromised. And those come from, it could be just fungal infections, you could have thrush, you could have bacterial or viral infections, and some of the cold sores that appear during this time period would be from that herpes simplex virus reactivation, which we'll talk about right now. So herpes simplex virus reactivation is quite common. There is an acute onset and it's quite painful. Typically, they present around the lips as well as inside of the mouth. This photo is perfect because it shows this roof of that blister before it gets unroofed. And when it gets unroofed, that's when you see that blister that's extremely painful. If we suspect HSV infection, then we do want to take a swab to send it for DNA testing. And at the same time, we might do other viral DNA testings as well. Typically, the way we manage this is with a magic mouthwash or lidobenalox that contains Maalox, Benadryl, and lidocaine. And, it's palliative. It'll just help you sort of control that pain for a little bit. And then sometimes systemic antivirals are indicated. Oral thrush is a very common complication in patients post-transplant. This is when that candida overgrows in your mouth, and that could be various reasons. You're immunocompromised, you've been on chronic use of antibiotics. It could also be because you're on topical or systemic steroids. Some steroid inhalers like fluticasone could also be a cause of you developing thrush. So if you use that inhaler, you don't rinse your mouth, then you could develop thrush. These can appear different ways. One, you can have this hairy presentation. This is the pseudomembranous candidiasis form. You can also have this redness, this erythematous form. Now, this is a photo of a patient that developed pseudomembranous candidiasis in the back of the throat. Management typically is topical antifungals like clotrimazole that we usually allow dissolve in the top of the tongue. And this is really important as that close contact with those tissues and letting that time with that antifungal is critical. And sometimes if this can be added to your systemic antifungal prophylaxis if you're already on antifungal therapy. Sometimes you will get these ulcers from your medications, and that is the sirolimus-induced oral stomatitis. This occurs when you have excess circulating levels of mTOR inhibitors, and these levels are very high systemically, causes mucosal toxicity. And it may form these painful aphthous-like ulcers with the well-demarcated borders, as well as this focal erythema. Now, management, it looks definitely, different than the viral induced ulcers. The management here typically is topical steroids using magic mouthwash, and then again working with your physician. If these lesions are really bad, then we would want to communicate with your physician and talk about possibly adjusting your sirolimus dose. We sort of talked about the non-GVHD related oral complications, and now let's talk a little about the symptoms that you might experience as you have oral chronic GVHD. The symptoms really vary widely, but one of the most common ones is dry mouth. This can present very suddenly. You were okay one day, and then the next day, your mouth just feels extremely dry. You might realize that you need to drink more water to just swallow your food. You can start forming these blisters on the roof of your mouth called mucoceles. These mucoceles are these immune cell infiltrates that sort of block the opening of the salivary glands. Your salivary glands continue to produce saliva, and this sort of gets underneath that surface and then forms this fluid-filled vesicles or lesions. And I'll show you some photos later, but those are some of the presentations that we might see, when we do our thorough exam. You can see these red and white patches in your mouth that do not scrape off. You can start seeing some mouth ulcers that are related to GVHD, and we'll discuss this in a little bit too. You can start seeing these white lines on the cheek lining of other parts of the mucosa called lichenoid striations or lichenoid patterns. That is a classic sign of oral chronic GVHD. And in addition to dry mouth, one common symptom that patients report is oral sensitivity, and that is to spicy foods, citrus foods, lemons, acidic foods that you were able to tolerate before, but now you're extremely sensitive towards it. And just understanding, some of these symptoms that could arise, these could be these trigger signs and early signs of the onset of oral chronic GVHD. Now, going in a little bit detail of the oral manifestations of chronic GVHD, and it could be in 3 domains. The first domain is the mucosal lesions. You might see this red and white striations, that lichenoid pattern that we just talked about. You can have these hyperkeratotic lesion presentations as well. Again, the white and red lines that could be all around, the palate, the gingiva, and the tongue as well. And these are the mucoceles that I just talked about that present to the roof of the mouth. You can see some of the areas are red and looks irritated. You can have these ulcers that form as part of GVHD. And surprisingly, these ulcers, they're not really painful if you're not eating or drinking or touching it. And oftentimes, the redness, this lichenoid striations or these ulcers are the first signs that the patients themselves notice because it starts just looking different. But these aren't really the first signs that develop. You might start seeing some patchy hyperkeratotic tongues. And so that is the mucosal domain. We also have the sclerosis, the perioral sclerosis domain, which is the limited opening. And this could be directly related to your temporomandibular joints, or it could be related just due to that sclerotic tissue around your mouth. And then the third domain is the salivary gland dysfunction, which we'll discuss in the next slide. But that is, of course, when you start having dry mouth, and then you have all these oral sensitivities symptoms as well. Now, salivary glands can be a target of chronic graft versus host disease, and this is when the immune cells start infiltrating the salivary glands, particularly the acinar cells that produces saliva in your salivary glands. It's important to know that you might not have any mucosal lesions, but still have salivary gland involvement. And one of the reasons why dry mouth is particularly important to notice and for us to ask about is due to your increased risk of cavities. So a lot of the patients with xerostomia or dry mouth, they experience this smooth surface caries. And this is a common pattern of caries that we see in patients that kind of sip on pop or juice all day. And unfortunately, and even other, medical conditions like Sjogren's syndrome, these patients have dry mouth and present with similar smooth surface decay patterns. This is a slide just to sort of highlight it's a data from the NIH cohort showing the 3 different domains that we just talked about: oral mucosal lesions that you can experience, salivary dysfunction, limited mouth opening. And this is to show that all of these different domains or presentations can happen independent of each other. So you might have oral mucosal lesion presentation, but have no salivary dysfunction, or, vice versa. And it's really important that we understand this as, the pathologic mechanisms is different, one, and so then the treatment regimen should be different. So to diagnose chronic graft versus host, number 1 is if you see that lichen planus changes, that is a hallmark of that clinically we can say that, you are having some symptoms of chronic GVHD. And especially if you have other symptoms or other presentations, such as dry mouth, mucoceles, ulcerations, mucosal atrophy. And if possible, when possible, we do want a biopsy to have that more confirmed diagnosis. And so we can rule out other possible diagnoses, oral infections, drug reactions, or new cancers that we kind of talked about earlier. These are some images I just wanted to share to show some of the diagnostic features of oral GVHD. So these are some of the lichenoid lesions that we talked about. It'll be these white lines, red lines around your buccal mucosa, as well as this is the inner part of your lips, your gingiva there. You can also have different presentation of in the palate. You can clearly see that patients just develop differently. So they could have these striations, but some could just have that erythema, that redness on the roof of the mouth. And some patients could present with these mucoceles, but not everyone. Your tongue could present differently as you experience oral chronic GVHD. So you might have the atrophy of the papillas that are important for tasting in your tongue. You can see that glossy presentation, that shiny presentation, and that is called atrophic glossitis. We might have these hyperkeratotic patchy areas of your tongue, and then another, patchy tuft keratosis presentation of the tongue. And it's important to note that, you and your physician as well, when they're looking at it, this is not oral thrush. It kind of looks like it, but if you look at it clear and, do additional exam, we know that it looks like it, but it's not candidiasis. Pseudomembranous ulcerations is a common feature and a distinct feature in patients with oral GVHD. These ulcerations can form underneath the tongue, around in the buccal mucosa that we saw in the earlier photo too, and as well as around the lips. Now, diagnosing salivary gland or asking about your salivary gland function is very important. So your dentist should be asking you about, when you kind of present with these symptoms, asking about, is your mouth suddenly drier? Is it progressively drier? Do you have difficulty eating, drinking food without addition of water? Are you taking some medication that could even exacerbate this? So for example, you're on antidepressants, and this could actually exacerbate the dry symptom that you already have secondary to GVHD. So it's an important discussion to have. And if you did get total body radiation or a more targeted radiation, like around the head and neck area, then your risk of salivary gland dysfunction is high, of course. But an important note is that a biopsy is actually needed to confirm or have a formal diagnosis of this, and typically they would do this in the minor salivary glands. So let's talk about the preventative measures. And one of the things I wanted to, that we like to emphasize is that there is no level of dental hygiene that would have prevented you from getting oral GVHD. So this is not your fault at all. But good oral hygiene can help reduce some of the complications that you might experience as you go through those GVHD symptoms. good brushing twice a day. That's always the answer when the dentist asks you. That's important. And also getting your routine dental cleanings. That's very important. And whether you need antibiotic prophylaxis depending on your medical status, but so getting that routine exam and cleaning and that oral cancer screening is really important. And there are some therapies for different stages of GVHD symptom presentation. So if you experienced mucositis early on in your transplant process, one of the ones that we talk about is cryotherapy, which is essentially having or holding ice chips in your mouth, or other cold therapy that really helps alleviate some of these pain symptoms. Sometimes we offer or we recommend our patients to use supersaturated calcium phosphate rinses, and this is to help that wound healing process. So that is something that we sometimes recommend for our patients. And of course, adequate pain control is important. One of the things that we don't have on this slide is red light therapy, which is photobiomodulation therapy. I'm sure you guys have heard of it at some point. A lot of the dermatology, maybe on TV or social media, you see advertisements of it, like bathe your whole body or your face with, get younger, all that stuff. But anyways, it actually really works. It is part of the supportive oral care for oral mucositis for adult populations. It's been since it's at least I think it's 2019 or so when they updated that guideline. But it really helps help with that pain and the healing of mucositis. So that is something that you can explore, and there are handheld devices that you could purchase, but we have to make sure it provides the right power, right wavelength. But most of the hospitals, or a lot of the hospitals, are trying to implement it in their practice to help these mucositis symptoms. So topical therapy for GVHD patients, the first line is dexamethasone oral rinses. This is actually the first line therapy that's available. The response rate is like 30 to 60%. And, you might think that it's not really high, but it's actually good considering that there is not a well-established second line therapy. This oral dexamethasone oral rinse is really important. The most important part of it is giving an adequate time in your mouth, and that you hold it in your mouth with that recommended time. You put a timer, make sure that it is touching your tissues before you spit it out. And that is the one way that's going to be most effective in helping you with some of these GVHD symptoms. If you have lichen planus-like changes or oral ulcers, like discussed, steroid rinses are helpful. If you are sensitive towards steroids, then calcineurin inhibitors like tacrolimus rinses can also be used. If you have an isolated ulcer in your mouth, and we know those are going to be painful, sometimes topical steroid gels or tacrolimus gels are used, and we also saw. I'm also seeing that you can also do an intralesional injection of triamcinolone. And this is something that the rheumatologists use a lot to help with joint pain. This is something that I probably wouldn't do on my kiddos, but for more of the adult patients I could tolerate. I have heard that it's very effective when it's directly applied to that ulcer bed. Aids for dry mouth. One of the things that we recommend is sugar-free gums and candies. And again, I want to emphasize sugar-free aspect of it. Oftentimes, these candies or gums have xylitol, which is the alcohol-based sugar that a lot of the oral the carcinogenic bacteria in the mouth cannot metabolize. So so you don't get cavities. So make sure it's a sugar-free gum if you're going to suck on it all day. Lemon flavors can stimulate saliva. So this is something, to kind of help you with your dry mouth symptoms. Obviously, keeping yourself well hydrated is important, frequent sips of water. And there are some lubricating rinses that we recommend, and one of them is Biotin. And these have these, it lubricates it. It's pretty basic, and it also helps with maintaining that hydration aspect of it. And it's something you have to find what works best for you, and then working with your dentist to figure out what could help you in the long run. There are prescriptions that could be provided in patients with dry mouth, and some of the medications, pilocarpine or Salogen and Evozac is listed here. Now, this only works if you have functioning, at least some functioning salivary producing cells in your salivary glands. And it does take quite a bit of time to show full effect. But important to note is this might not be medically indicated or medically appropriate for you. So again, discussing this with your dentist and then your physician who's managing your GVHD symptoms will be very important. I'm going to go back to fluoride. Fluoride is critical for your oral health and then preventing the decay. So check your toothpaste if it has fluoride. Again, the fluoride rebuilds that dental enamel, especially those areas that have softened and demineralized. So make sure you check that it does contain fluoride. And some of the modern toothpaste contain active hydroxyapatites that's helped rebuild the tooth enamel. So that's something that you can explore as well. But I don't think there is good long-term large clinical trials that have looked at how effective hydroxyapatite containing toothpaste is in compared to fluoride containing toothpaste. Remember, the reason why fluoride is important is because when you have dry mouth, your risk of decay increases, and especially because, saliva that buffers that acid and basic capacity in your mouth, and then it also returns that calcium to that damaged enamel. So if you have less saliva, your teeth are less protected, so you gotta protect it extra by using fluoride toothpaste. When you have that sclerotic perioral or like limited opening presentation, some gentle intraoral, extraoral massages could be helpful. And especially doing this, with a physical therapist or occupational therapist could be helpful. And they might develop a program, using stacked tongue depressors and then adding another tongue depressor gradually to help you increase that opening. So that physical therapy can really help. And in some very, very severe cases, they do provide perioral steroid injections or do surgical interventions as well. Now, as we kind of talked about everything, oral chronic GVHD is very persistent. It's still a very difficult complication that affects quality of life of a lot of our transplant patients. And this is just to show some of these treatment modalities that have been tested in randomized controlled trials. A lot of these are topical steroid rinses. Response rates vary from low 50s to 70s. And the effectiveness kind of varies to everyone. And one important thing is that it does not cure the symptoms, right? And so the point of this slide is to kind of show that more clinical trials are necessary to develop more of those targeted therapies to help with some of these symptoms that the patients might experience. There is one clinical trial that's open in Madison, Wisconsin. So if you're from there, maybe you want to check it out. This is a different kind of approach where they use a autotransplantation of your mesenchymal stromal cells from the bone marrow and directly deliver it to your salivary glands and they're looking at whether that could improve the dry mouth symptoms. So I'm going to look into. Dr. Mays wanted me to share this with you guys. So if you have any questions, you can definitely contact her as well. So the last thing I wanted to, or second to last thing I wanted to end with is another study that is ongoing right now, which is using red light therapy to help oral GVHD symptoms. And this trial specifically is looking at the efficacy and safety, testing the efficacy and safety of this red light therapy. And like I said, this has been extensively used in controlling and alleviating some symptoms and healing symptoms of oral mucositis. The way this works is it's a non-invasive light therapy, and at a specific wavelength, it could really help increase healing, reduce inflammation, and reduce pain. And this is very invasive, not invasive, sorry. So I'm particularly excited about this because I've been starting to see more and more children, and older children that are experiencing some chronic GVHD symptoms. And we are already trying to implement the red light therapy for mucositis management. And it just seems so easy, to provide, especially if it's going to help with that pain control and that inflammation. So something I would definitely, I'm looking forward to the results, and hopefully something that you guys could follow too. So key points, see your dentist regularly, especially after your transplant has stabilized. I will admit a lot of the dental part of your whole medical list, the dental is usually on the end of the list. And oftentimes when I see my patients back, it's been like 5 years post-transplant, and they have a full mouth decay, or they're just having all these symptoms. It's easy to kind of forget about it because there's a lot of things on your list, but just at least doing the routine regular cleanings could really help prevent a lot of these complications, or help notice it so we can help manage it early on. And of course, take care of your mouth by brushing and flossing every day. All right. Thank you so much for your time. I work very closely with children undergoing hematopoietic cell transplant, and when they're admitted, and they are a very, very dear part of my just me in general. They've taught me so much, and their resilience is amazing, and I just learn from them a lot in general. And the parents are amazing, and they are surviving. They are becoming older, and so I'm kind of on the other end right now, talking to you guys, but I really appreciate this opportunity to be here and share this passion with you guys all. So I'm happy to take any questions. Yes.
No.
You went over some medical aids
Yeah.
for graft versus host, or graft versus host. Will those help improve the food sensitivities at all? Is that known?
That's a good question. I don't know about food sensitivity. Usually, it's more like with lichenoid lesion presentations that we see, and then and that could present with the food sensitivity or just isolated. So that's something I could ask Dr. Mays about as well in the long run. Could it help like the taste perception or the sensitivity towards food? But the taste, I will say, what we see is that perception of or changes in taste can gradually improve on its own. So hopefully, you don't need topical steroids for that.
Thank you.
Any questions?
Okay. Okay, so we're gonna break for lunch. Thank you so much. And so I believe that lunch is out there and being served, and then we'll go back over to the other side for the keynote presentation and panel discussions, and I think that's it for that part. Thank you.